Dr. Rebecca Scalzo is an associate professor of medicine at the University of Colorado Anschutz Medical Campus and a research scientist at the Rocky Mountain Regional VA Medical Center. Her research aims to better understand the diabetes burden in premenopausal women through the investigation of the link between type 2 diabetes and estrogen signaling. The primary themes of her research program are 1, to determine the interaction of type 2 diabetes and estrogen signaling on skeletal muscle mitochondria, and 2, to elucidate the mechanisms by which endocrine therapies for breast cancer increase type 2 diabetes risk in cancer survivors. Thank you, Dr. Scalzo, for being here today. I will stop sharing my slide and then hand over our Zoom to you. Oh, Dr. Scalzo, you're muted.
I just realized that, and I didn't know how to come off. All right. Now you see my screens and you can hear me, right?
Yes.
Okay, cooking with gas. Great. Thank you very much for that introduction and for having me here today to talk about diabetes risk in women treated for breast cancer with endocrine therapies. So my plan today is to give you a short background of how this topic became part of my research portfolio. I'll also take that time to highlight my collaborators and acknowledge their contributions, because without them, none of this would be possible. And then I'll get into kind of the meat of the issue and cover why type 2 diabetes risk in breast cancer survivors is an important topic that should be on all of our radars, and then move into the questions that we're trying to address with our preclinical and clinical work. So first, a little bit of background. I'm an exercise physiologist by training with a focus on skeletal muscle metabolism. I came to the University of Colorado to do my postdoc with Dr. Jane Roosh to get into the diabetes space with a specific emphasis on sex differences in women's health within the diabetes world. Because of that component of my research, I'm a member of the Ludeman Family Center for Women's Health Research. And through that interaction, I met Dr. Liz Welberg, who at the time was here at the University of Colorado. She is a mammary gland biologist who studies breast cancer development. And when we met, she had just become interested in diabetes risk in breast cancer survivors and needed some support on the diabetes side of the equation to move a project forward. So that's kind of the genesis of how we started working on these projects together. Down the road a little bit, we brought in Dr. Heather Leach from Colorado State University because she is a behaviorist who studies the implementation of exercise behaviors in cancer survivors. By adding her, we were able to make our research a lot more translational. And today I'm excited to share our combined work with you. So that's a little bit of the background on how we started working on type 2 diabetes and breast cancer. So I'll shift to a little bit of background on diabetes in breast cancer. So breast cancer is the most prevalent invasive cancer in the world. And thanks to research and advancements in therapeutics, it's a highly treatable disease, with most patients living decades after therapy ends. In 2020, there are almost 8 million women alive who had been diagnosed with breast cancer in the previous 5 years. Breast cancers are often characterized by the receptors that they express, and most breast cancers express the receptors for estrogen. What this means is estrogen is, you can think of it as the fuel for the cancer. When it signals through its receptor, that's what causes the cancer to grow. Therefore, a lot of treatments are designed to interfere with estrogen receptor signaling. There's two main trajectories that this interference can come from, at least that I will talk about today. The first are called SERMs, or selective estrogen receptor modulators, and these block estrogen receptor signaling in the breast and in the breast tumor. The other trajectory that you can choose with estrogen or with endocrine therapies are aromatase inhibitors. So in a woman, makes estrogen either, or well, both, from her ovaries, but also from converting testosterone to estrogen with the enzyme aromatase. So if you have a woman who's either gone through menopause or has had her ovaries removed, you can block any additional estrogen production by blocking that aromatase enzyme with aromatase inhibitors. So the number of women surviving estrogen receptor positive breast cancers highlight the power and importance of these estrogen receptor targeted therapies. However, the use of these agents is linked to an increased risk for the development of type 2 diabetes. My colleagues and I recently published a review where we cover the entire history of endocrine therapies for breast cancer. So on this timeline here, the events with the blue dots below the line represent FDA approvals of drugs, and then the red dots above the line just mark notable events. So if we start at the beginning, tamoxifen, the most common SERM, was invented in 1963 and was approved by the FDA for treatment of breast cancer in the late 70s. The first aromatase inhibitor trials were in the early 80s, and you see their approval here in across the 90s by the FDA. What I'd like to highlight is in 1984, we have our first report of tamoxifen and dyslipidemia. So dyslipidemia is high cholesterol and high triglycerides, and this is part of the metabolic syndrome, which you can consider a precursor to the development of type 2 diabetes. In 1992, we have our first report of SERMs and excess body weight, and then in 1995, the first report of tamoxifen specifically and the development of NAFLD. NAFLD is non-alcoholic fatty liver disease. It's now called MAFLD, metabolic associated fatty liver disease, but this is ectopic accumulation of lipids in the liver, also a hallmark of that like precursor stage to the development of type 2 diabetes. In 2006, we have the first report of linking diabetes to previous breast cancer, and then this expanded in 2012 and then beyond, linking the endocrine therapies specifically to diabetes risk. So, and these reports continue all the way up through 2023. So I will point out that these epidemiological data that have been collected are all from women with breast cancer. So that's why my colleagues and I have focused our work on female physiology in women. We acknowledge that men get breast cancer. We just don't really understand diabetes risk. So we're going to kind of shelve that topic for today and focus on women with breast cancer. So what do we know from these studies about type 2 diabetes risk in women treated with endocrine therapies? Most importantly, about half the cases of type 2 diabetes in breast cancer survivors can be directly attributed to the effects of their endocrine therapy. So this is when we control for all the other variables that could be leading to type 2 diabetes. About half of these cases, like I said, are due to their endocrine therapies. And what's interesting is that the adverse effects of these endocrine therapies appear to be more prevalent in women with overweight and obesity. And this is an important component that we try and model in our preclinical work. When we started working on these projects, there was very little known about how endocrine therapies could be driving risk factors for type 2 diabetes, but we had some clues from those epidemiological studies. Greater adiposity, hepatic steatosis, so that's that fatty liver disease, and then insulin resistance were all associating with endocrine therapies. So we had some ideas of where to look. It's important to understand why type 2 diabetes is something that we need to be avoiding in women with type 2 diabetes. Like, what's the big deal about type 2 diabetes? This is a disease that more than 10% of the US population has. It's chronic, but it's pretty well, it can be well managed depending on your relationship with your physician. But it's important to know all of the risks associated with type 2 diabetes, because it will impact nearly every system in the body, limiting health span and quality of life, and will also drive premature mortality. So from this cartoon, you can see that diabetes touches everything from your head to your toes. So if you have type 2 diabetes, you're at greater risk for having a stroke, cerebrovascular disease, you're more at risk for blindness, for dental disease, for peripheral vascular disease, for losing limbs due to amputation, for neuropathy, which is painful, nephropathy, which is problematic for a lot of reasons. And the reason our group is so focused on type 2 diabetes is because of this cardiovascular disease risk. So Most people, 80% of people with type 2 diabetes will die from cardiovascular disease risk. And because we're talking specifically about women today, I would highlight that cardiovascular disease risk with type 2 diabetes is different between the sexes. Generally, we consider women have this extra benefit of cardio protection. We're less likely to have cardiovascular disease and cardiovascular events compared with our male peers. However, when a woman is diagnosed with type 2 diabetes, we say she loses her cardio protection. And actually, a woman has about 50% greater excess risk of cardiovascular disease events associated with her diabetes compared with a man. So since we're specifically talking about women today, I wanted to highlight how much of a morbidity and mortality burden this type 2 diabetes diagnosis will be and is for breast cancer survivors. Additionally, there's a relationship between diabetes and cancer. So if we start this cycle here, a woman is diagnosed with an estrogen receptor positive breast cancer. In addition to other treatments, she'll likely be put on endocrine therapy. Like I've said, that endocrine therapy will likely or could lead to increased risk for type 2 diabetes, which in and of itself is problematic. However, that type 2 diabetes will drive the risk for reoccurrence of that breast cancer, kind of kicking off this really nasty cycle. My colleagues and I would like to break the cycle here between endocrine therapy and type 2 diabetes. I do want to make it clear that at no point are we suggesting that endocrine therapy should be pulled off the table for women with breast cancer. They obviously are important life-saving treatments. Our goal is to understand how they're driving diabetes risk so we can come up with a different, either a concomitant treatment, be it a pharmacological agent or a lifestyle intervention that can modify that diabetes risk while taking an endocrine therapy. So that leads to kind of the important 10,000-foot question, which is, why do these endocrine therapies disrupt metabolism and lead to type 2 diabetes? And we, even before we started our preclinical work, we had the very easy answer of there are estrogen receptors in pretty much every tissue in the body. So if you disrupt estrogen receptor signaling with either a SERM or aromatase inhibitor, while it's going to have a beneficial effect on the breast cancer that you're trying to treat, you're also going to target other organs in the body. You can see from this cartoon that the liver, the pancreas, skeletal muscle, and adipose tissue, which are all important organs either for the maintenance of metabolic health or the path to type 2 diabetes, all have estrogen receptors in them. And if you alter estrogen receptor signaling in these tissues, you will get a whole body phenotype of insulin resistance. So the body won't respond to insulin as well and taking up glucose, so you'll end up hyperglycemic. It'll alter how the adipose tissue can expand. It'll change how the liver one responds to insulin, but also develops steatosis, so the accumulation of lipid and collagen to make it a fibrotic tissue. So we know from just pure estrogen receptor research that disrupting these tissues would be bad from a diabetes standpoint. But at this point, or at least when we started, we really didn't know specifically what was happening with these endocrine therapies. I want to take a minute before I get into that to just summarize what we do know up to this point. One, more and more women are surviving breast cancer because of endocrine therapies, which is a great thing. Two, these therapies appear to increase risk for type 2 diabetes, especially in women who have overweight and obesity. And three, that type 2 diabetes is really concerning. One, because of its own morbidity and mortality, but also because of the link to cancer recurrence. So that brings us to the two primary questions my colleagues and I have been trying to address over the last couple of years. The first one is both the most simple and complex to answer, is what drives greater type 2 diabetes risk with endocrine therapies? And this is where we're really focusing a lot of our preclinical and in vitro work to try and answer this question. But secondly, and probably more important, what can we do about it? Like I said, we at no point will ever say that endocrine therapies need to go away as part of breast cancer treatment. We need to figure out what we can do that's effective alongside of these endocrine therapies to mitigate some of this type 2 diabetes risk. So to that end, getting into a little bit of our work, I'll start with our preclinical studies trying to address this first question. What is driving greater type 2 diabetes risk? So we use a mouse model for these questions, and we feed them either a low fat, low sucrose diet or high fat, high sucrose diet. And we do these two different diets because of what we've learned from epidemiological data, that nutrient overload, nutrient stress, or excess adiposity drives or exacerbates some of the effects of these endocrine therapies on metabolism. So we wanted to be able to replicate that clinical phenotype in our mice. All our mice are kept in thermal neutral conditions because this helps mice fed a high fat diet develop obesity, glucose intolerance. It just makes it a better model to translate to humans. We overactivize all of our mice, and immediately after that, we supplement them with estradiol, and we maintain them like that until we were ready to begin the study. At that point, our mice are divided into 3 treatment groups within each diet. So we have our estradiol group, which we consider our control group. We have estradiol plus tamoxifen, which is modeling SERMs in a clinical population. And then we have our estradiol withdrawal group, or e-withdraw. So remember I said that aromatase is the enzyme that converts testosterone to estrogen in humans. Mice don't have functional aromatase, so we don't need to give them a drug to prevent that extra estrogen production. So if we overactimize them and then remove any supplemental estradiol, it mimics that same condition as aromatase inhibition in humans without having to add an extra drug to the layer. So when you see withdrawal, you can consider that mimicking aromatase inhibition in humans. And also of note, our goal when we analyze the data from these studies is to compare how these different treatments, so tamoxifen or e-withdraw, how they compare to estradiol treatment within their diet and then across diets. Our goal is not to look at how tamoxifen compares with e-withdraw from a basic science standpoint. That's an interesting question, but from a clinical relevance standpoint, that's beyond the scope of our project, so we don't make that comparison. So the first thing we look at is body weight accumulation in the weeks post-treatment. So from this dashed gray line, how did body weight change? And what we see is that the animals fed a high-fat, high sucrose diet, so always indicated here by the warm colors, gained more body mass compared to their low-fat comparators, and that's to be expected. Within the high-fat, high sucrose diet, the tamoxifen-treated animals, these orange dots, and then the e-withdraw animals, the light pink dots, gained more body mass compared with E2 alone. And you even see in the low-fat animals that e-withdraw caused a change in body mass, which is not unexpected considering the importance of estrogen to energy balance and energy expenditure. We wanted to know where this change in body mass came from, so we looked at body composition. So we saw no differences in lean mass. So this is muscle mass between the different animal groups, but we did see differences in fat mass. So what you see here is that the e-withdraw animals in both diet conditions, so light blue and light pink, have greater adiposity, and so too do the tamoxifen treated animals. So they gained body mass and they gained it all with greater adiposity. These data are just the first step to confirm that our model is working to replicate what we see in the clinical population on these therapies. Next up, we wanted to look at glucose tolerance and insulin resistance. So diabetes modeled in rodents is a little bit funky because diabetes is clearly a human disease designed, or diagnosed with human endpoints that we can't replicate in mice. We don't look at A1C in mice. We don't look at fasting glucose and have a cutoff of 126 in mice. Those things just don't align. So instead, we can look at glucose and insulin and their relationship and see differences between our groups and then have suggestions about development of type 2 diabetes. So here we looked at fasting insulin and fasting glucose in our animals, and we found that the high-fat animals had greater insulin and glucose, which is to be expected with that kind of a diet. The e-withdraw animals, so mimicking aromatase inhibition, had greater insulin concentrations, while the tamoxifen-treated animals had greater glucose. We look at the relationship of these two variables together to get an estimation of insulin resistance. So the lower the number over here, the less insulin resistant or the more metabolically healthy an animal is. So as you'd expect, the high-fat animals were more insulin resistant, but this insulin resistance was exacerbated by tamoxifen and e-withdraw. So again, we're mimicking what the epidemiological data would say about the clinical population. We also looked at glucose tolerance with the glucose tolerance test. So we give them a glucose load at time 0, and then we watch the glucose excursion over time. You see that high-fat fed animals, so all the warm colored lines are higher, greater than the low-fat animals, and that's replicated over here in the graph of the area under the curve. What you'll also notice is that the e-withdraw animals had an exacerbation of this glucose intolerance on the high-fat diet. So taken together, the slide previous in this, we have a good model to try and figure out why these endocrine therapies or how these endocrine therapies are disrupting glucose tolerance and insulin sensitivity within this system. So from here, the next step was to pick an organ and see what happened. So we started with the liver because almost all of the human data included liver endpoints to suggest that these endocrine therapies were causing ectopic lipid deposition in the liver, hepatic steatosis, so lipid plus fibrosis development in the liver. And when the liver becomes steatotic, it's insulin resistant, so it doesn't respond appropriately to insulin, produces excess glucose, and it disrupts cholesterol homeostasis. So that would also make sense with why these women would be developing type 2 diabetes. So we looked at the livers from these animals. You see the low-fat fed animals are on top and the high-fat fed animals on the bottom. And there's a noticeable difference in lipid accumulation. The white dots are lipid accumulation. I would much rather my liver look like the E2 liver fed a low-fat, low sucrose diet compared with this E-withdrawal liver down here fed a high-fat, high sucrose diet. But there were no significant differences between the groups for this measurement. We also looked at hepatic steatosis scores, and while there was some variability, and again, I would much rather have the low-fat liver than a high-fat liver, there were no significant differences, and there were no differences in relative liver mass. So while these livers don't look great, they also don't appear to be the smoking gun for type 2 diabetes development with these endocrine therapies. So our next step was to look at the subcutaneous adipose tissue. So subcutaneous adipose tissue is a really important storage bin for metabolic health. It's a place where you can put away extra lipid, extra glucose, and keep it out of circulation so it's not impacting anything else. And it's kept far away. It's not like visceral adipose tissue around digestive organs that will impact the function of anything else. So subcutaneous adipose tissue is really important in the development of type 2 diabetes. And what we found is that the relative weight of this depot was greater in the high-fat fed animals compared with low-fat fed. Then the weights were greater specifically with the tamoxifen and the E-withdraw treated animals. So they've got relatively greater adiposity. When we looked at the morphology of these tissues, we found that the low-fat animals had these nice, tight little adipocytes, lots of little cells, while the tamoxifen treated and the E-withdraw animals had lots of really big cells. The high-fat fed E2 animals fell somewhere in between. We measured the diameter of every single cell in these slides, and what we found was that exactly what our eyes told us. Low-fat fed animals had lots of little adipocytes, but tamoxifen treated and E-withdraw treated animals had lots of very large adipocytes. That's also represented here, just on the average diameter across the entire section. So why is this important and why would this happen? So adipose tissue can expand in response to nutrient overload or storage need in one of two ways. You can either make lots of new cells and put a little bit of lipid into each cell, or you can not make any more new cells and just overfill whatever you have available. You can think about this as like closet storage within your house. Like you're always accumulating new stuff, or at least my house, we're always accumulating new stuff. If you're expanding your closet, the number of closets you have, like you just keep building new closets. No closet will ever get too full. Your house stays happy and picked up. In terms of physiology, these cells don't get overfull, they maintain their insulin sensitivity, and they're associated with metabolic health. You want lots of little adipocytes. Alternatively, if you stop making new ones, so think about you continue to accumulate stuff at your house, but you don't have any way to build more closets. Your closets become overfull and the doors are spilling. It causes stress in your house. The same thing happens in your adipocytes. There is a finite amount of lipid that can be stored in an adipocyte. Once it's full, it starts to spill out and go into circulation and go to other organs like your liver. It causes the accumulation of macrophages. That's what all these little black dots are. And this adipocyte phenotype associates with insulin resistance, type 2 diabetes, and cardiovascular disease. So if we go back to our slide looking at our different adipocyte phenotypes, you see that on the endocrine therapies, we get these large overfilled adipocytes, which could be leading to the insulin resistance. So why are they ending up with these large overfilled adipocytes? To answer that question, we used a sorting pattern to see what different potentials the adipocyte tissue had. So we sorted out the stromal vascular fraction. We used a sorting strategy to get the precursor cells, which either are progenitors or preadipocytes. Preadipocytes are only going to become adipocytes. It's like you get what you get and nothing more can be added. Progenitors, however, can divide one progenitor into two progenitors. So you get two red cells. It's like storing closet building material in your backyard. You always have the potential to add more. You can also divide a progenitor into one progenitor and one preadipocyte. This is like saying, hey, I think we need to build one new closet today, but let's also add to our potential to build more in the future. So you want to maintain a large pool of progenitors to be able to expand in the face of like a high-fat diet or obesity or excess adiposity. When we looked at these cell populations in our animals, we found that tamoxifen treatment and withdrawal of estradiol resulted in greater preadipocytes. So there's a lot of committed cells available, but especially in the context of the high-fat diet, the tamoxifen treated, and even there was a signal from the e-withdrawal treated animals are losing their ability to expand in the future, meaning these cells are getting overfull because they don't have the opportunity to make more adipocytes. This overfilling results in lipid spillover into circulation, which will go to organs that you don't want adipose tissue to accumulate in, like the liver, like skeletal muscle, and will also alter insulin sensitivity. We followed up some of these studies with time courses in animals showing that this is what happens first, this adipocyte phenotype. It happens very early in the first 2 weeks. And also looking at cell culture models, driving home that it's the estrogen disruption of estrogen signaling that's happening. So we've really been able to pinpoint that it's a disruption of adipocyte expansion that is causing this diabetes risk in endocrine therapies. We wanted to see, though, from our mouse model, is this replicated in human tissue? So we were able to get human samples from women with obesity and women who were lean, who were either treated with tamoxifen or not, and look at their adipocyte size. And what we found is the women with obesity, so the ones with the biggest nutrient stress, when they're treated with tamoxifen, had the largest adipocyte diameter. So that coincides with our animal research. And these large adipocytes associate with greater BMIs, suggesting that the phenotype we see in our animals is what's going on in humans. So to try and synthesize all of that in the only way I know possible is with cartoons. So to summarize, estrogen binds to its receptor, and it normally drives adipose tissue expansion through making new adipocytes, so cells within the adipose tissue. When you block this signaling pathway, either with aromatase inhibitors or with SERMs, what you end up doing is driving adipocyte hypertrophy, or the overfilling of the existing adipocytes in the subcutaneous adipose tissue. This will cause lipid spillover into circulation. So that's that dyslipidemia that they noticed even back in the 1980s. These lipid species will end up in the liver, they'll end up in visceral adipose tissue, and they'll cause insulin resistance at the skeletal muscle and hyperinsulinemia coming from the pancreas, so making more insulin there. All these things are considered the precursor to the development of type 2 diabetes. So this is kind of where we are in our understanding of how these endocrine therapies are driving type 2 diabetes risk in breast cancer patients. Our next steps for the preclinical studies are to try and identify what pharmacological strategies we can layer on top of either tamoxifen or e-withdraw mimicking aromatase inhibition. Our goals are to use the readily available pharmacological agents that are already out there. So one thing we're looking into is metformin, is what happens when we layer metformin on top of these endocrine therapies. Metformin is the first line treatment for type 2 diabetes. It does a lot of things that we either do or don't know how it does them, depending on who you ask. But the consensus is it limits hepatic gluconeogenesis, so how much glucose the liver is putting out, which helps just maintain glycemia overall and either prevent the conversion to type 2 diabetes or at least maintain or try and control glycemia within the context of that disease. The other drug we're using is a little bit more interesting, I think, which is pioglitazone, which is one of the TZDs. So TZDs help expand subcutaneous adipose tissue through making new adipocytes. So it kind of combats the exact effect of the endocrine therapy in helping build up that adipocyte population. We chose pioglitazone specifically, though, because in addition to targeting adipose tissue, it has a secondary effect on the liver in limiting ectopic lipid deposition there. By limiting that extra lipid in the liver, that should help control a little bit of the glucose. So those are the next steps that we're taking with our preclinical studies to try and understand how these different drugs would interact with endocrine therapies to reduce the risk of diabetes in this population. But while we're doing that, we're also trying to move towards a more clinically relevant study design. So that's where I'm going to transition here and talk about the clinical study that we've been doing with Dr. Heather Leach. And it all starts again with understanding that endocrine therapies with breast cancer cause glucose intolerance, greater adiposity, and insulin resistance. These things all lead to type 2 diabetes. What we can harness here, however, is that these variables here in the middle are not specific to breast cancer patients. This is garden variety path to type 2 diabetes. So we can go to the literature that's already looked into how to either prevent type 2 diabetes or treat type 2 diabetes and see what we can pull from there. And one of the best, if poorly utilized treatments or prevention strategies is physical activity. So physical activity does target all of these variables and will prevent type 2 diabetes in a population at risk for the disease. But I told you at the beginning I was an exercise physiologist. It should have been a warning that those of us who study exercise, physical activity is a really complicated variable, and we like to pull it apart and annoy all of our friends and colleagues with it. So physical activity includes a lot of different things. It's an umbrella term. So if you want to think about it from the exercise standpoint, planned, moderate, and vigorous intensity physical activity is considered exercise. But you can also have light intensity physical activity. So that's puttering around the house, doing your chores indoors. You can have physical activity that's moderate or vigorous intensity that's not exercise. That's like doing your yard work outside if you're breaking a sweat and breathing hard. But things like sedentary time are also components of physical activity. How long do you sit in a day? How long do you stand up for when you do break your sedentary time? And then the relationship of those variables. Do you sit for 30 and stand for 10? Do you sit for 60 and stand for 5? What do you do while you stand? Do you stand and look out the window, or do you do some light intensity physical activity? You can see that if you get some of us in a room, we're going to talk ourselves in circles about all the different variables associated with physical activity and how they could influence diabetes risk in breast cancer survivors. The take-home message is there's really a lack of knowledge regarding how physical activity can improve metabolic outcomes related to the development of type 2 diabetes, specifically in these women receiving endocrine therapies. Physical activity is complicated And it's currently unknown whether any of the improvements we see in diabetes risk down here are related to changes in physiological outcomes like aerobic fitness. Does it matter how much your exercise changes your fitness, or how your exercise changes your glucose homeostasis? Or is it something completely different, like how all of your light intensity physical activity throughout the day alters your energy expenditure? And that could be something that targets one of these variables in the middle. But even more complicated is there has been one study that looked at sit to stand transition, so breaking up sedentary time in breast cancer survivors. And that was actually a more powerful predictor of insulin sensitivity than exercise was. So what I'm trying to tell you is, or what I'm trying to say is that we don't know anything about anything when it comes to physical activity and diabetes risk in breast cancer survivors. And we have to know something before we can design a clinical trial to study it. So Dr. Leach and my goal was to begin to understand these relationships between the different components of physical activity and how they related to glucose tolerance and insulin sensitivity in breast cancer survivors treated with either an aromatase inhibitor or a SERM. So we had two different projects that we ran side by side because they had the exact same study design, but our goal all along was not to compare SERMs to aromatase inhibitors. Just want to make that clear up front. So the design for this study was that we recruited women taking either a SERM or an aromatase inhibitor for at least a year. And we kind of didn't have a lot of other inclusion-exclusion criteria associated with it. We kind of wanted to get a nice cross-sectional population. The first visit, we had them do an oral glucose tolerance test. So this is where they have to drink the nasty, like flat Sprite, if anyone's had the pleasure of doing an oral glucose tolerance test. And then we measure glucose over time. We also were able to take serial measurements for insulin, so we could calculate or estimate insulin sensitivity as well. We also did a DEXA scan so we could measure adiposity, considering we know that the impacts of these endocrine therapies seem to be different based on a woman's overweight or obesity status. And we had them complete a lot of questionnaires about physical activity behaviors, sedentary behaviors, feelings about exercise, those sorts of things. The second visit, they came in and we did a maximal exercise test. We did this to measure aerobic fitness or cardiorespiratory fitness. That is because, one, we want to see how that specific variable relates to glucose tolerance and insulin sensitivity, because that could be how we design a study in the future. But two, we wanted to see how fit these women were. We know that cardiorespiratory fitness is one of the strongest predictors of all-cause mortality. So it also would be a really nice health indicator on these women. And then the last step was we gave them an activity monitor. It's called an Active Pal, and they wore it for 14 days after that. While questionnaires are great and all, no one really understands how active or not active they are. So this activity monitor characterizes every single minute of every single day. Were they doing physical activity? How intense was it? Were they sitting? How long did they sit? How long did they break up their sitting time? How active were they while they were breaking up their sitting time? There are a lot of data points that we can get from this monitoring system. And that was it for this study. So what we've been able to do, we finished our last participant in the last week or two. So I have right here is an interim analysis of our data. So like I said, our goal is not to compare SERMs to aromatase inhibitors, but we did for this interim analysis do a pooled analysis plus individual data assessments. And what you see here is our participants are in their early 50s. On average, they have a normal BMI and they've been on treatment for about 2 years. So that's describing our participants. When we looked at some of the physiological data, the first thing we looked at is fat mass here. So body fat percentage of about 40%. I'll tell you, there aren't cutoffs to say what's normal or what's not for body fat percentage, but I look at a lot of DEXAs for 30 to 60-year-old females, and this is actually pretty lean. We looked at their fitness. So this is peak oxygen consumption. Like I said, this is one of the strong predictors of it's cardiorespiratory fitness, strongest predictors of all cause and cardiovascular mortality. And what these numbers are is they're considered poor based on normative data for non-cancer population. So these data would suggest that, we've got some room for improvement from a health standpoint. But when we look at our physical activity data, we got a little bit different story. So we looked at steps per day. So they're taking right around 8,000 to 9,000 steps per day. To put that into context, in the US, the average is 3,000 to 4,000 steps per day. So this is obviously a lot more than that. In Colorado, we like to be a little bit extra. Our state average is about 7,000 steps per day. So even compared with our own state, our participants were relatively active. The next thing we looked at to get an idea of what who our participants were, was their activity score. This is something the ActivePal calculates based on postural changes. Every time you move, it assigns a metabolic equivalent or an energy expenditure associated with that change, and then spits out a score. This is proprietary to ActivePal, but what we do know is that 34 is considered active. So all of our participants are at least getting really close to being considered active, which aligns with our steps per day. The last two things we looked at were Matsuda Index and glucose tolerance. So Matsuda Index is an estimation of insulin sensitivity. The higher the number, the better. We don't have clinical cutoffs for that, though, because it's not something that's used in the clinical population very often. We do, though, have that for glucose area under the curve. So this is the total glucose excursion from that glucose tolerance test. And anything over 290 is considered glucose intolerance. And you see all of our means come under 290, but we did have about 30% of our participants that were over 290. So while they all seem to be relatively active, we do have some glucose intolerance in our participant mix. So with our interim analysis, our goal was to look at how these different variables related to each other to see if one of the activity variables or fitness best predicted either insulin sensitivity or glucose tolerance, so we can get an idea of where we should be heading next. So the first thing we looked at was VO2 peak, so cardiorespiratory fitness, related both to insulin sensitivity here with the Matsuda Index, but also glucose tolerance. And what we found was a significant positive relationship between VO2 and insulin sensitivity. And this is to be expected. The more fit you are, more insulin sensitive you generally are. We know this from the general population. We know this from the population with type 2 diabetes. So it's nice that relationship holds true here. It also gives us an idea that if we want to improve insulin sensitivity in these participants, we need to target cardiorespiratory fitness. As an exercise physiologist, this is my bread and butter. This is a standard aerobic exercise intervention where we're doing 45 to 60 minutes of moderate intensity exercise most days of the week. But this is something we can design a study for pretty easily. Interestingly, though, fitness did not associate with glucose area under the curve, and I would happily speculate as to why. But we really don't have any data as to support my speculations at this point. We did try models with fat mass, the steps, activity score, and sit to stand variables within this whole group model, and they did not associate with insulin sensitivity or glucose area under the curve. However, when we did pull out our two different treatment groups, we saw a different story for sit to stand transitions. So women treated with SERMs had a positive association, this is this teal line here, between sit to stand transitions and Matsuda Index. So the more they got up and moved around during the day, the more insulin sensitive they were, or less likely to develop type 2 diabetes. This relationship here in the green line, though, with aromatase inhibitors, you see is not significant and actually going in the exact opposite direction. So this is also really interesting and leads us to the potential to be designing specific lifestyle interventions for each endocrine therapy that women are on. Obviously, these are just some initial analyses. Once we get all of our data analyzed, we do, well, the statistician, this is way over my head. We plan to run with her lots of regression models to try and pinpoint what physical activity variable best predicts insulin sensitivity or glucose tolerance, so we can better define our next interventions. We'll include specifically percent body fat in the model, considering what we know about adiposity and the impact that has on diabetes development with endocrine therapies. But we'll also use other demographic variables. And then the last 3 bullets points just highlight the power of the active PAL. There's a lot of data we'll be able to pull from the active PAL to hopefully tailor any physical activity intervention that we want to do specifically for women taking aromatase inhibitors versus SERMs. So that's really our future directions, is a targeted behavioral intervention. We know from the sit to stand behavior in our interim analysis that it probably will be different between the 2 different treatment strategies. But it does seem that cardiorespiratory fitness will be involved in anything we do moving forward. So our goal is to have that out in the next, or all these data analyzed in the next 6 months, to hopefully have something to move forward with grant-wise and publication-wise. So with that, I'll acknowledge my 2 primary collaborators, Dr. Liz Welburn, Dr. Heather Leach, and our study team, specifically Ethan Clark. He's our PRA who collected all of our clinical data. And with that, I can take any questions.